Good morning and welcome to Global Healthcast, brought to you by Global Health Press. Once a week, we bring to you news and views about infectious diseases, vaccines, and vaccination. I am Joe Schmitt, and with me is Dr. Melvin Sanicas. Good morning to Switzerland. Good morning, Melvin.
Good morning, Professor Schmidt, and good morning, good afternoon, good evening to those who are watching us or listening to us today.
The topics today are the cold season, incidence of acute respiratory tract infections, and climate factors. And then Melvin will explain why during the cold season there are more respiratory tract infections. He then will present SARS-CoV-2 reservoirs and new mutations of this SARS-CoV-2 virus. Finally, he will cover Bangladesh and dengue. Bangladesh is hit by the worst dengue outbreak on record. I will sum up with vaccination and pregnancy, and I will speak about additional vaccine recommendations and the timing of vaccinations. Without further ado, here is acute respiratory tract infections over time. What you see here is from our former pediatric infectious disease acute respiratory tract infection network, where we tested with multiplex PCR hospitalization of children in 3 centers and areas in Germany, 2000 to 2008. And what you can see here, every winter, there was an increase in respiratory tract infection. No surprise, everybody knows it. But the news on this here is rhinovirus in green is the #1 organism, followed by RSV and influenza A. And RSV is certainly pediatric, but as we know today, it is probably also very, very common in adults. So this is what happens every winter. Now, the question is, are climate factors responsible for this increase every winter? And #1, what we show here in red line is the number of children hospitalized. So you see every winter RSV goes up, and this is for RSV only. And in blue is the temperature. So very clearly, RSV goes up if the temperature goes down. The temperature goes up, RSV disappears, temperature goes down, RSV pops up, and so on and so forth. But what you can also see is RSV is high every second year. High here, 2002-3, low here, whoops, high the next year, low the following year, and I tell you, but you don't see it, high again this year. So there is a rhythm. And the summary of the paper that I can highly recommend to you, it was published in 2009. Influenza A, RSV, and adenovirus are correlated with temperature. Once temperature goes down, these viruses cause more hospitalization among German children. Rhinovirus was correlated with the relative humidity. And most important, we did a time series model at the time to show that climatic conditions predict RSV outbreaks. So we know every second year there is a big peak, and we know and we can predict the timing of the RSV outbreaks every year. Melvin, any questions to this?
Not a question, Professor, but more of a comment on why these things happen, right? Later, I will show a slide on the biologic mechanism, but it's really also societal, social reasons, right? Because during the winter, if it's cold, we stay indoors. We don't go out. We close the windows. We stay indoors with our family and friends. So it's easier for these viruses to infect other people as well, right?
Yeah. So we agree it is multifactorial. If temperatures goes down, we go indoors, right? It's a correlate. It is, there is a tendency. We don't open windows anymore. There is more exposure. Now you have data to show immunological findings, why there are more respiratory tract infections during winter. Maybe you can explain this.
Yeah, so this study was published in the Journal of Allergy and Clinical Immunology last year. But I think this is important and needs to be emphasized. As you've mentioned, viruses like influenza tend to have outbreaks during the winter, and these viruses enter through the mouth and nose, but our nasal passages usually have strong defenses against them. But the cold weather, however, slows down our ability to clear the mucus in our noses, making it easier for these viruses to infect our bodies. And in this particular study, they looked at the role of nasal epithelium-derived extracellular vesicles, or EVs, in our innate toll-like receptor 3 dependent antiviral immunity. It's complicated. It sounds complicated, but basically, it's just showing us that there is a biologic mechanism regarding one factor of our innate immune response that is limited by colder temperature. In the study, they showed that reducing the temperature inside the nose by as little as 9 degrees Fahrenheit or 5 degrees Celsius um, kills nearly 50% of the billions of virus and bacteria fighting cells in the nostrils. And they basically showed here that cold air is associated with increased viral infection because you've essentially lost half of your immunity just by that small drop in temperature.
Very interesting. So it is multifactorial and many factors contribute to this increase. And actually, I guess we already have the cold season start in the Northern Hemisphere here in Central Europe. Mm-hmm. So very interesting. Thanks for the explanation, Melvin. And we'll keep you posted on that one because I think this is extremely important. Now, Melvin, you have another one on the reservoir of the SARS virus.
Yes. So we have been talking about COVID, long COVID, but this article reviews studies that have identified SARS-CoV-2 RNA or protein or immune response indicative of a SARS-CoV-2 reservoir in long COVID, or what we call the Post-Acute Sequelae of COVID, right, or the PASC. And I think the main messages here is that, one, persistent viral RNA or protein can engage host protein recognition receptors that can provoke cytokine production and inflammation. Second, the reservoir may contribute to microbiome imbalance. Microbiome activity contributes to priming of the immune system. So it is possible that the microbiome dysbiosis could predispose people to altered acquisition or altered clearance of SARS-CoV-2 infection. The third one is that SARS-CoV-2 reservoir can induce antibody response that are cross-reactive with host proteins. At least this is one mechanism of molecular mimicry that they call. And I think the last one is that the reservoir could also contribute to non-specific PASC or long COVID symptoms, including fatigue, trouble concentrating, muscle and joint pains, and others. And so it's really just showing us the potential mechanisms how SARS-CoV-2 as RNA or SARS-CoV-2 protein in our system can contribute to long COVID or the PASC.
In a SARS-CoV-2 special, we just interviewed a few experts on the topic, and there are many, many hypotheses why there is long COVID. The important thing is there may be a reservoir, and this is what you show here. There are very good arguments that there is persistent virus reservoir. From a public health point of view, maybe 15% of people with SARS-CoV-2 infection may come down with long COVID. And this is a major cost factor and actually societal factor because these people won't be able to work for some time or for a very long period of time. Mm-hmm. Very nice, Melvin. And you also brought us some news on the variants of concern and on mutations.
Yes. So the reason why I showed this is because we always hear about new variants and numbers, right? And this one is particularly talking about the BA.2.86. And if you see the image on the screen, the first row you will see comparing BA.2.86 from the BA.2. The second one is comparing this particular variant with the variant that came out of Wuhan. The third one, the last row, you will see BA.2.86 comparing it with XBB.1.5. And the reds that you see are the mutations. So the message is there are several mutations between that are actually new in the BA.2.86 compared to the different other variants. And you know, if we didn't have vaccines or we didn't have immunity from SARS-CoV-2 infection itself, this variant would have been called a variant of great concern because it's particularly new, right? But thanks to vaccination and immunity from the virus itself and our immune system, we are not back to 2020 or 2021 in terms of serious cases from COVID, hospitalization, and deaths from COVID. So just to remind people that really our immune system is great. That's one. And secondly, we are benefiting from vaccines and immunity that we get from SARS-CoV-2 itself.
Yeah, I thank you for stressing the importance of vaccination. If also vaccines are not perfect, COVID vaccines are not perfect, specifically in this case, but they contribute to reducing mortality. And I think this is the real big benefit of vaccines here. And again, we should have told, or people should have told the people that these vaccines are not perfect, as any of the respiratory vaccines don't reduce colonization. You don't get sterile immunity with vaccination. Melvin, you have another very important piece on something we worry about very much, which is dengue.
Yes. So at the moment, Bangladesh is experiencing the most severe dengue outbreak on record, according to the WHO. And climate change has been mentioned as one of the reasons for contributing to the spread of the mosquito-borne disease in Bangladesh. Since the outbreak began in April this year, there have been more than 135,000 cases and more than 650 deaths recorded. And only on a single day in August, there have been 300 deaths reported. So I think that's actually really alarming. And the outbreak is putting a lot of pressure on the health system. Cases are beginning to decline in the capital city, Dhaka, but they are increasing in other parts of the country. And also on this slide, I just mentioned here that a combination of factors, including climate change and the El Nino warming weather, contributed to the dengue outbreaks in Bangladesh and also in other countries in South America, for example.
Yeah, bad news. And I think we will hear more of dengue. We also have a dengue special with the new tequila vaccine that was licensed in Europe a couple of weeks ago. And actually, there is an implication of all of that, and you have some more information on the community response in Bangladesh.
Yes, so here you will see the efforts by the community, by the government to help with this outbreak. So we have this public service announcement on dengue prevention that you will see on TV, on Facebook, on social media. You will see this community awareness sessions, dissemination of messages by healthcare workers. And also on the upper right of your screen, you will see this young actress who died from dengue last month. And this is one of the reasons why dengue really became a topic of conversation for the country, because one famous personality died of dengue in Bangladesh. And as you know, dengue is normally self-limiting for most people, but for some people, you could be getting a serious case and you could die. And at the moment, there is no dengue vaccine approved in Bangladesh.
Yeah. But they are responding with all types of actions, as you can see on the screen. And I think awareness is very important, and that there is a public response. Mm-hmm. This is very sad news, Melvin, but I'm afraid we will hear more of these stories in the future, and we will keep you posted on dengue. Vaccination in pregnancy is the next topic, and I covered influenza, Tdap, and COVID-19, and these are recommended in the United States routinely. They are not licensed, but they're recommended. Now, in addition, certain other vaccines can be given under special circumstances. For example, if there is a meningococcal ACWY outbreak, you could give men ACWY vaccine, or if the pregnant woman lives in one household with a person who sheds the hepatitis B virus, she also could get vaccinated if she has not had the vaccine before. So these are recommended under special situations. Not recommended is HPV because there is no data. The zoster vaccine is not recommended because the old one was a live vaccine, which must not be given during pregnancy. And second, the adjuvanted vaccine should not be given during pregnancy. There are concerns there because of the adjuvantation. Contraindicated are all the live vaccines listed here. This is the situation in the United States, and very similar the situation in the United Kingdom. JCVI is recommending the same vaccines for pregnant women, similar under certain circumstances. Here they have the live attenuated vaccine in the no recommendation, and they took it here from the contraindicated. And again, small differences, but basically the same principles. Now, this is what you should do as an obstetrician gynecologist. And I also want to highlight a little bit the timing of vaccines and vaccination. And I want to encourage you to look up the recommendations for your countries. The recommendations vary a little bit. For example, here I have United Kingdom, Spain, and Germany, influenza, Tdap, and COVID. Here in Germany, influenza vaccine should only be given from the second trimester, only any trimester here, United Kingdom, Spain, or the United States. Tdap, again, different recommendations, 6 to 32 weeks of gestation, 17 to 36, 28 to 30. Look, the evidence is all the same, but they give different recommendations. Isn't that funny, right? Scientists. And then COVID-19, you really have to look up your specific recommendations in your countries. Melvin, any comments on vaccination and pregnancy, on the timing, or on the additional recommendations?
Just with your comment on the any trimester in the second trimester, Professor, because I think it also has something to do with how the different national immunization technical advisory groups really look at the data and how I would imagine that in Germany, even if they know that it's safe for any trimester, they always think that miscarriages happen in the first trimester, so they just want people to not associate the vaccine if anything happens during the first trimester. You know, it's more like a being risk averse, I would say, and maybe Spain and United Kingdom, they are not thinking the same way.
Yeah, actually for influenza and from the second trimester, I guess the story is that there was what they called chorioamnionitis in the studies, which was just some lymphocyte infiltration in the placenta and no real clinical chorioamnionitis, right?
Yeah,
but it is, right, as you say, it is a different interpretation of data. Some are more towards the benefits, and as you say, some are more looking into the risks, and you come up with different recommendations. But they're all science-based, right? Let me sum up. So what we covered today is the cold season, and RE incidences go up depending on the organism, if temperature goes down or with humidity, or rhinovirus, for example. And Melvin nicely explained to you the immunological reasons why that may be, in addition to other factors like crowding and living inside and not opening the windows. He showed you why there may be SARS-CoV-2 reservoirs in the body, some hypotheses, and these may contribute and result in long COVID. He then covered new mutations of the SARS-CoV-2 and how the immune system really helps us to be protected despite new variants coming along. He told you about Bangladesh and the dengue outbreak there, the largest outbreak on record. And I just covered vaccination and pregnancy, additional vaccine recommendations, and when you should give the vaccine. We have a cartoon again today, and actually this young couple gives a toast to vaccines. They thank vaccines as they don't need to have 10 children in hopes that just 3 or 4 of them will live to adulthood. And this is why this young boy from Africa is puzzled by the fact that people in rich countries refuse vaccines and vaccination. Melvin, thank you very much for all your presentations. I give you the last word, and at this point, I say goodbye.
Yes, thank you, everyone. Thank you for listening and watching us. Stay safe. Get your vaccines before the winter cold season.